Hello and welcome to this lesson, osteoporosis. So osteoporosis is a systemic skeletal disorder characterized by low bone mass and microarchitectural deterioration of the bone tissue, and this leads to increased bone fragility and higher risk of fractures. So in the normal bone density with T score is less than -1, more than -1, meaning that it should be minus 0.9 or so. So in case of a person who is suffering from osteopenia, the T score is -1 to -2.5. And in case of osteoporosis, the T score should be less than -2.5. And we define osteoporosis with a bone that has a T score of less than -2.5. So now let's talk about the pathophysiology behind osteoporosis. So bone is a dynamic tissue and it's constantly remodeling via two processes. We have osteoclast activity, we have osteoclast, which means bone resorption, and we also have osteoblast activity, which means bone formation. So in a normal person, there's a balance between osteoclast and osteoblast activity, and in case of osteoporosis, we have an imbalance between osteoclast and osteoblast. But note that for having osteoporosis, there have to be imbalance favoring bone resorption. If we have an imbalance which favors the osteoclast activity or bone resorption, as the result, the patient is going to have osteoporosis. If the imbalance is in favor of osteoblast activity, in that case, we have osteopetrosis, which is another pathological feature. Now, what are the mechanisms of developing osteoporosis? Number one, we have decreased osteoblast activity. It means that we have reduced bone formation. Number two, we have increased osteoclast activity. It means that we have excessive bone resorption. Number three is when we have imbalance in hormonal regulation. And note that estrogen is one of the most important hormones for keeping the balance between osteoclast and osteoblast activity, and especially in a woman who are having estrogen deficiency, for example, postmenopausal woman, or the patient who is suffering from, for example, Klinefelter syndrome, we are going to have imbalance in hormonal regulation, and as the result, the patient is going to develop osteoporosis. Another cause of osteoporosis is nutritional deficiencies, and as you know, the calcium and vitamin D are especially important materials for having bone mineralization. So when you have calcium or vitamin D deficiency, the bone mineralization is going to be impaired, and as the result, in long term, the osteoporosis can develop. And the last one is chronic inflammation. Note that chronic inflammation and diseases that are chronically inflammatory diseases, these can promote osteoclast and bone resorption, and also the treatment. The treatment, for example, if the patient is suffering from rheumatoid arthritis, the treatment is glucocorticoid, which promotes osteoclast activity. So chronic inflammation in general and the treatment can cause osteoporosis. So of course, we are not going to talk about bone remodeling in details. We are going to dedicate another video to the bone remodeling and osteoclast and osteoblast activity. But here is some of the roles of the estrogen in keeping the balance between osteoclast and osteoblast activity. So first of all, note that in order to activate the osteoclast cells, we need attachment of the rank ligand to the rank receptors on the osteoclast. So estrogen is actually one of the hormones that inhibits this attachment. So as the result, we have less osteoclast activity and less bone resorption. Also, estrogen is inhibiting some inflammatory cytokines like interleukin 1, TNF alpha, TNF beta, and interleukin 6. These inflammatory cytokines actually cause osteoblast transformation to the osteoclast. So estrogen inhibits that. So as the result, we have less osteoclast and less bone resorption. Another role of estrogen is that estrogen actually promotes the apoptosis of osteoclasts. So when we have less estrogen, less apoptosis of osteoclasts, less inhibition of transformation of and activation of osteoclast, and as the result, we have increased osteoclast activity, and as the result, we have more bone resorption. So the osteoporosis can happen. So now let's talk about types and classification for osteoporosis. So we have two main classification for osteoporosis. We have primary osteoporosis and secondary osteoporosis. So primary osteoporosis can be subdivided to the type 1, primary osteoporosis type 1, where we have which we call postmenopausal osteoporosis. So in this case, this is occurring predominantly in the woman after menopause, and this is due to decline in the estrogen level. So estrogen, as we talked, it plays a crucial role in maintaining the bone density by reducing bone resorption, and usually affected bones are commonly trabecular bone, which can be found in the spine, wrist, and hip. So this leads to vertebral fracture, distal radial fractures like Colles fracture, and pathophysiology is usually with increased osteoclast activity due to reduced inhibition of the rank L by estrogen. So usually the women between 50 to 70 are more prone to postmenopausal osteoporosis. We have type 2 primary osteoporosis, which also called age-related or senile osteoporosis. And this occurs in the individual usually more than 70 years of age due to natural aging process. Both men and women are affected, but women are at greater risk because they have one additional risk factor, which is called menopause. So affected bones are usually cortical and trabecular bone. This is leading to the fracture in the weight-bearing bones like hip and vertebra. So here we have reduced osteoblast function or bone formation and decreased calcium absorption from the gut, which actually contributes to this problem. So we have other risk factors for primary osteoporosis, also vitamin D deficiency, reduced physical activity due to the age, and a slower bone remodeling with the age. So now let's talk about secondary osteoporosis. And here we have many groups of disease that can cause secondary osteoporosis. The first group of diseases are endocrine disorders. And first disease is hyperparathyroidism. In case of hyperparathyroidism, we have increased parathyroid hormone level. This leads to excessive bone resorption by osteoclast activation, reducing bone mineral density, and this is commonly causes cortical bone loss, increases the bone fracture risk, especially in the long bones. In case of Cushing syndrome, we have chronic glucocorticoid excess, which inhibits osteoblast function, promotes osteoclast activity, and reduces calcium absorption in the gut. This results in decreased bone formation and increased bone resorption. In case of hyperthyroidism, we have excessive thyroid hormone, which accelerates bone turnover with resorption outpacing the bone formation. This leads to trabecular bone loss, especially in the hip and spine. We have hypogonadism, and diseases like Klinefelter syndrome and Turner syndrome. So low level of sex hormones, estrogen and testosterone actually impairs bone remodeling and decreases peak bone mass. In case of Turner syndrome, we have estrogen deficiency as a key factor, while in the Klinefelter syndrome, we have testosterone deficiency, which plays a major role in osteoporosis. Number 5, we have diabetes. So we have two types of diabetes mellitus. We have type 1 and type 2. In type 1 diabetes mellitus, we have reduced bone formation due to insulin deficiency and impaired osteoblast function, which actually depends on the insulin level. In type 2 diabetes, we have poor bone quality due to advanced glycation end products, which is affecting collagen and bone matrix despite normal or even increased bone density. So the second group of diseases that can cause secondary osteoporosis are gastrointestinal disorders. And number 1, we have malabsorption syndromes like celiac disease or Crohn's disease. So impaired absorption of calcium, vitamin D, and other nutrients that are essential for bone health due to intestinal damage or inflammation is underlying cause. Chronic inflammation in conditions like Crohn's disease can increase bone resorption through cytokine-mediated defect. Another cause of gastrointestinal is chronic liver disease. In case of chronic liver disease, liver is responsible for production of 25-hydroxyvitamin D, which is precursor for vitamin D activation. So when we have chronic liver disease, we have less activity or no activity of 21 hydroxyvitamin D. So as the result, we will have vitamin D deficiency, and this contributes to the secondary osteoporosis. In case of bariatric surgery, which is the third cause in gastrointestinal, we have for example, bariatric surgeries like gastric bypass. The patient is going to have reduced nutritional absorption, and this is particularly important for calcium and vitamin D, which leads to the decreased bone mineral density and rapid weight loss, and also hormonal changes after surgery can further contribute to the bone resorption. Also, we have nutritional deficiencies. So nutritional deficiencies are actually very important here. For example, the patient might have vitamin D deficiency. So vitamin D deficiency leads to impaired calcium absorption, because vitamin D is very important for absorption of the calcium in the gut, causing secondary hyperparathyroidism and increased bone resorption. This results in reduced bone mineralization and increased risk of fracture. We can also have calcium deficiency. So chronic calcium deficiency at intake stimulates the parathyroid hormone secretion, increasing bone resorption in order to maintain the calcium level of the blood, and this leads to gradual loss of bone density. And the third cause in the nutritional deficiency is actually protein malnutrition. So inadequate protein intake reduces bone matrix synthesis, for example, collagen, and muscle mass. This increases the risk of falls and fractures, and also severe protein deficiency can also impair calcium and vitamin D metabolism in its own way. So another group of disease that can cause secondary osteoporosis or rheumatological disease like rheumatoid arthritis and systemic lupus erythematosus. Again, recall that these two diseases are chronic inflammatory conditions. So chronic inflammation promotes osteoclast activity. And another thing that you have to know for your board examination is that the chronic glucocorticoid therapy that is used for treatment of these two conditions are also promoting the bone resorption and inhibits bone formation. Also note that in the severe cases of rheumatoid arthritis and systemic lupus erythematosus, the patient will have reduced physical activity due to severity of the disease, and this also contributes to the bone loss. So another group of disease that can cause secondary osteoporosis is chronic kidney disease. And here, due to chronic kidney disease, we have secondary hyperparathyroidism, chronic stimulation of the parathyroid hormone due to vitamin D deficiency because of the kidney, calcium deficiency due to calcium loss through the kidney, or chronic kidney disease that can increase the bone resorption, and this results in the cortical bone loss and fracture. Another point is that due to chronic kidney disease, the patient may have renal osteodystrophy, and chronic kidney disease actually disrupts the calcium, phosphate, and vitamin D metabolism, and this leads to secondary hyperparathyroidism and impairs bone mineralization, and this results in a mix of high turnover, or what we call osteitis fibrosa, and low turnover or adynamic bone disease osteoporosis. So another cause for secondary osteoporosis is medications that we are using for treatment of diseases. For example, chronic glucocorticoid therapy. So glucocorticoid in long term inhibits osteoblast activity, reduces calcium absorption in the gut, and increases bone resorption, and this leads to rapid bone loss, especially in the trabecular bones like spine. Anticonvulsants like phenytoin or phenobarbital, because they induce cytochrome P450 enzymes, this accelerates the vitamin D metabolism and reduces its active form. So as the result, the patient will have chronic vitamin D deficiency, and this results in the impaired calcium absorption, and bone mineralization as the result will be impaired as well. So the patient will have osteoporosis, secondary osteoporosis. So another group of disease are aromatase inhibitors like anastrozole. So decreased estrogen level by inhibiting its synthesis by these drugs leads to increased bone resorption and decreases bone density. So it is commonly used in postmenopausal women with breast cancer. So this is the indication for aromatase inhibitors, but they can lead to osteoporosis in the long term. Androgen deprivation therapy is another cause of secondary osteoporosis. Lower testosterone level, which are essential for maintaining the bone density in the men, can cause osteoporosis. This leads to increased bone turnover and increases loss of cortical and trabecular bone. Another drug that can cause secondary osteoporosis are proton pump inhibitors and chronic use of them. So reduced stomach acid production impairs calcium absorption, and in the long term they are associated with increased fracture risk. So heparin can be another cause. So in the long term, heparin promotes bone resorption by altering the osteoblast and osteoclast activity. So prolonged use can lead to bone loss and fracture and osteoporosis. Another cause is SSRIs or selective serotonin reuptake inhibitors. So these may affect bone remodeling by altering serotonin signaling in the bone cells, and they are associated with decreased bone density and increased fracture risk, again, particularly in the long bones. Now, what are the clinical presentations of osteoporosis? First of all, note that this is a silent disease. It is going to be asymptomatic until a fracture occurs. So what are the common fractures in case of osteoporosis? We have vertebral compression fracture, we have distal radius fracture, which we call Colles fracture, and also we can have proximal femur fracture, and they can cause chronic back pain because of vertebral collapse, loss of height, or kyphosis in case of vertebral compression fracture. So what is the diagnosis? What are the diagnostic tools that we can use for the osteoporosis? Number one, we should have bone mineral density measurement with DEXA scan. Again, for the normal bone, we have more than -1, -0.9, and so on and so forth. If the patient is osteopenic, we have DEXA scan measurement. We have bone mineral density measurement between -1 and -2.5, and more than -2.5 is characterized as osteoporosis. So we can do other diagnostic tests, and we have laboratory tests. So calcium, phosphate, and vitamin D level. So for the calcium, we are measuring calcium to assess if dietary or serum calcium level are sufficient or insufficient. Hypocalcemia can stimulate parathyroid hormone secretion, and this is going to lead to the bone resorption. Phosphate, when we have imbalance in the phosphate level, for example, if the patient has hyperphosphatemia in the chronic kidney disease, can affect bone metabolism and mineralization. Vitamin D is essential for calcium absorption and bone mineralization, and deficiency can lead to secondary hyperparathyroidism and increased bone turnover, contributing to the osteoporosis. Parathyroid hormone. So in order to evaluate primary hyperparathyroidism, we are measuring parathyroid hormone, and it is a common cause of secondary osteoporosis. So elevated parathyroid hormone leads to increased bone resorption in order to maintain the serum calcium level, and it leads to cortical bone loss. Thyroid function test to check if the patient is having hyperthyroidism, which accelerates the bone turnover by increasing the osteoclast activity, leading to net bone loss. Thyroid abnormalities are another common cause of osteoporosis. So liver function test, the liver is crucial for converting vitamin D to the active form. So chronic liver disease can impair this process, reducing calcium absorption and bone mineralization. So kidney function test, if the patient is suffering from chronic kidney disease, they can have altered calcium, phosphate, and vitamin D metabolism, leading to secondary hyperparathyroidism and renal osteodystrophy, and can exacerbate the osteoporosis. And another important marker is alkaline phosphatase. So elevated level of alkaline phosphatase means that we have increased bone turnover. So it is often seen in the diseases like Paget disease and hyperparathyroidism, or even healing fracture, or other causes that can cause elevated alkaline phosphatase. So bone-specific alkaline phosphatase can help to pinpoint the bone-related causes. And we have a marker which is called osteocalcin, and it's a marker of bone formation, and it is useful to assess the rate of bone remodeling. So elevated level of osteocalcin may indicate that we have active bone turnover, which is often is imbalanced and in favor of osteoporosis. Another diagnostic tools that we can use is X-ray, but it is usually reserved for the advanced diseases. If the patient is having very high score in the DEXA scan, you might see cortical thickening and vertebral compression fracture in the X-ray. So this is a difference between a normal bone, osteoporosis, osteopenia, and severe osteoporosis. This is a cortical bone and this is trabecular bone. As you can see, in the normal bone, we have very good density. In osteopenia, we have gradual loss of bone density. And in case of osteoporosis, as you can see, the bone is very weak and very prone to the fracture. And also in the trabecular bones as well. So here you can see that we have very good bone structure, but as the disease progresses to the osteopenia, we have greater trabecula, and when we have osteoporosis, we have complete loss of the bone structure and bone architecture. So now let's talk about differential diagnosis for osteoporosis. Number one, we have osteomalacia. So in case of osteomalacia, the patient is going to have bone pain and muscle weakness, and in the laboratory, you are going to see low vitamin D, low phosphate, and elevated alkaline phosphatase. We have Paget disease of bone, where you are going to see elevated alkaline phosphatase and thickened, disorganized trabecular bones on the X-ray. So another differential is multiple myeloma, where you are going to see osteolytic lesions, hypercalcemia, and M spike in the proteins of the plasma. Another differential is metastatic bone disease, where you are going to see pathologic fractures, history of primary malignancy, elevated alkaline phosphatase, and hypercalcemia. Also, you have renal osteodystrophy as a differential, where you have bone changes due to chronic kidney disease, and here you are also going to see elevated parathyroid hormone and secondary hyperparathyroidism. Now let's talk about management of the osteoporosis. So first of all, we have lifestyle modification. So weight-bearing exercises, smoking cessation, limiting alcohol are essential lifestyle modifications that the patient can use in order to prevent the progression of the osteoporosis. We can have nutritional supports and giving nutritional supports. For example, calcium intake between 1000 to 1200 milligram per day. But note that the calcium has some side effects. For example, it can cause constipation, bloating, and gas. Also increases the risk of kidney stone, and this is actually happening with excessive supplementation. It's better to be taken with the meal because it is better absorbed. And note that you have to limit dose per intake, because the body can only absorb about 500 to 600 milligram of calcium at the time, so split the doses throughout the day. Hydration is very important in order to avoid the kidney stone, and also encourage the patient to have increased level of leafy greens because they are great resources for the calcium. Another supplementation is vitamin D, which should be given between 800 to 1000 international units per day, and it is actually helping the absorption of the calcium. Also, sunlight exposure is a very good source for the vitamin D, because actually it can create vitamin D in the body. And also note that because vitamin D is a fat-soluble vitamin, it is better absorbed when it is taken with the dietary fat. Another treatment, actually the first line medical treatment for the osteoporosis, is biphosphonate, like alendronate or zoledronate, but they have also some side effects. They can cause heartburn, nausea, and esophageal irritation. They can also cause muscle and joint pain, and they have a rare but very serious side effect, which is called osteonecrosis of the jaw and atypical femur fracture. So they have to be taken in the morning with the empty stomach with a full glass of water. the patient has to stay upright in order to avoid esophageal irritation, and long-term administration needs to be actually assessed after 3 to 5 years due to potential risk factors that it has. So another important point about biphosphonate is that if the patient is taking alendronate, the dentist should be informed because they can have because the dentist can do invasive dental procedures, and actually alendronate increases the risk of problem in those procedures. So another drug that we use is denosumab. This is the second line treatment. It comes with the name of Prolia, and it has some side effects. For example, it can cause rash, eczema, or cellulitis, increases the risk of infection, especially urinary or respiratory tract infection, and it also have a rare but very serious side effects like hypocalcemia, osteonecrosis of the jaw, or even atypical femur fracture. So this is a rank L inhibitor, and usually we are scheduling injections. So one injection, subcutaneous injection for every 6 months. And another treatment that we can do for the osteoporosis is hormonal replacement therapy. So this is usually done for postmenopausal women. Of course, it can increase the risk of venous thrombosis, so you have to be very careful. And another treatment that we have is selective estrogen receptor modulators, right, like raloxifene. So raloxifene also has some side effects. It can cause hot flashes in the postmenopausal woman. It can cause leg cramps. It can increase risk of blood clots, for example, deep vein thrombosis or pulmonary embolism, but it has benefits for the bone. So it reduces the risk of vertebral fracture, but does not actually affect the hip fracture risk very greatly. So it has cardiovascular risk, so avoid in the patient who has history of DVT or a stroke or myocardial infarction. And it is also actually benefiting patients who are also suffering from breast cancer or at risk of breast cancer. So it reduces the risk of estrogen receptor positive breast cancer and makes it suitable for the women who are at the high risk. So thank you for watching. See you in the next video.